Hi, everybody. This is Dr. Andrea, physical therapist, and I'm beyond excited to have my good friend and colleague, Dr. Kristen Herbst, on board today. And she specializes in orthopedic surgery and sport specificity. Return to play is going to be the topic of discussion today. So, welcome, Kristen, and thank you so much for taking time to do this.
Thanks for having me, Andrea. I'm excited.
Welcome to Expect More with Dr. Andrea, the podcast where we cut through the noise and get real about healthcare, physical therapy, and what it means to truly take charge of your health in today's ever-changing world. I'm Dr. Andrea Davis, physical therapist, straight shooter, and your go-to for no-fluff conversations that challenge the status quo. From the front lines of patient care to the big picture changes in the system, we're diving into what's working, what's not, and how you can expect more for yourself, your care, and your life. Real talk, real solutions, no settling. Let's get into it. Yeah, so excited because this is near and dear to our hearts, and this really comes out of multiple private conversations, right, around the around the epidemic, so to speak, of just sports medicine in general, let alone the we could probably talk all day about the women breaking into sports medicine as well, both on the provider side and what they need on the player side, on the athlete side. So if you can please just tell everybody, what you do, where you started, and what you're passionate about at this stage in your career.
Sure, yeah. So as Andrea said, I'm an orthopedic surgeon. I specialize in sports medicine. My intro to sports medicine actually started as an athletic trainer. I went to undergrad with athletic training as my major, and it wasn't until I had to see one of my lacrosse athletes in undergrad have an ACL reconstruction that I said, "Oh my God, I want to be doing that." I loved athletic training, but the surgical side of it just kind of brought me in and grasped me. So I worked hard to do all my prereqs, get into med school, and then kind of focused on getting into orthopedics. You kind of mentioned it's a pretty slim pickings in terms of female orthopedic surgeons. We're only about 6 to 8% of the entire orthopedic surgery community. But I was able to just kind of stick to it, and I was able to accomplish it. I did my sports medicine fellowship out in Cincinnati, and then I've been at a couple different places in practice. I started out in New Jersey. We connected in South Jersey, and is kind of where our surgeon physical therapist relationship started. It has continued. I value your friendship and your knowledge base, so we always touch in and make sure that we keep connected and learn from each other. So this is really good that we're getting to talk about this stuff, more than just between the two of us now. And then I went to upstate New York, initially in the Oneonta and Cooperstown area, where I really got to specialize in sports medicine as one of the only sports medicine people in a large geographic region. I was there for about 5 years. And then for the last 2.5 years, I've been in Binghamton, New York. I get to be the team orthopedic surgeon for a Division I college athletic program. We have a semi-pro hockey team in town that I get to take care of. So a lot of good stuff, and my practice is like exclusively sports medicine, which was my goal all along. It's been a great little kind of not a straightforward path. I've kind of gone a roundabout way, but I got what I wanted, and here I am, and happy to talk to you about some of the stuff that we're doing at our facility.
Yeah. I mean, I feel like the path is really extra special to me, just generally speaking, because not only do you walk the walk as an orthopedic surgeon, but you walked through the shoes of an athletic trainer and the on-field challenges and the true importance of what they do as a first line of defense on injuries on the field. What we've talked about off and now on is our level of expectation has been challenged along the way. It's been challenged along my 25 years of hearing, why do you care so much? Whatever, not everybody's doing it that way. And like you said, you saw surgery and you were like, I want that. I saw, some of the professional teams, how they were cared for. And I was like, I want to do that, but I want to do that for regular people that don't know that that's out there. Right. So,
absolutely. No, I think I can relate. even with the teams that I've worked with, a lot of the athletic
Mhm.
trainers make comments like, you can tell you used to be an athletic trainer. Like once you don't lose that, you know. The other thing is in my course of working as an athletic trainer, I did work in a physical therapy clinic. And it was like half the day in the PT clinic working side by side with a physical therapist. And then the afternoon I went out and covered a community college. So I do have that, you know, the extra rehab exposure that not a
Yeah,
lot of, surgeons have.
they're not. Yeah,
So I think I know where there's a chance that there could be hiccups in the rehab. And I don't know, I have high expectations of the people around me because I want my athletes to do so well. And so sometimes I know it's frustrating for people when they probably wish there was just a surgeon that just kind of just do whatever you want kind of thing. And I'm more
yeah,
involved
yeah,
in it. So I
yeah.
think it's like hit or miss whether people like that or not. But ultimately, I'm finding my little team that really likes that, and we engage well, and we, you know, help each other out. And I think it's, you know, a little team. So yeah.
Now you mentioned earlier that you recently presented at a professional organization on the specificity of rehab and return to play, and that you got an exceptionally warm welcome with that on a topic that you and I agree should be uh, that's what you do, right? As
Yeah.
far as, you know, get as close to your, if you want to teach somebody in PT, if somebody comes into PT for me and they say, all I want to do is be able to go up and down the stairs, there's not a chance that during our rehab, we're not going to go up and down the stairs. So, you know, you get a pitcher that comes in and say, I just want to be able to throw without pain. How are we not in physical therapy making that a regular part of our ability to put people back on the field and assess the efficacy of our treatment plans if we're not putting them through those paces? So if you could speak to that a little bit, I would love
Yeah.
that, because this is like my bread and butter, my heart and soul. It's why I'm here. It's my purpose for,
Yeah.
you know, doing this podcast, as well as reaching out into the community. So please talk to us about it.
Yeah, I think my answer is kind of twofold because you could touch on a couple of things there. I think number one, I say that my practice is 100% sports medicine. And when I say that, it's 100% sports medicine type surgery. So not everyone that I see that needs a ACL reconstruction, a labral repair, a rotator cuff repair, not all of them are true athletes in our sense of,
Mm,
you know, competitiveness. But we have
sure.
weekend warriors. We have even like people that got hurt on the job. So every time I see a patient in the office, I actually have an athletic trainer work with me in the office. She's great.
That's
And
awesome.
she knows when she's rooming the patient, between the both of us, we know when that patient leaves that visit, what their occupation is, what their recreational activities are, if they're like, you know, out and a regular person. If it's a high school or college athlete, where do they go? What sport do they play? What position do they play? Because that really comes into
Yes.
play a lot of times. Because, you know, your goalkeeper is going to have totally different demands. Your overhead athletes, totally different demands. So I know what sports everyone plays and or what job we're getting them back to, because those are the types of things. So you're one of your patients, I just want to be able to walk up and down the stairs. Well,
Sure.
yeah, that's what you're going to target. That's what you're going to do. So same thing. You know, I'm going to do the same surgery, but what we're expecting from them or how fast we get them back or may be different. So that's kind of that
Totally.
part of it. Do you want me to talk about my recent presentation, or do you want to kind of keep going with
Yeah,
that?
no, we totally can. Let's talk about your recent presentation, and then I can comment, interject as we go, if that's okay.
Yeah, yeah.
Yeah, lay it
So
out.
I recently presented, there's a group called the Women's Forum. It's a women's
Okay.
sports medicine group. Everyone in
Love
the
it.
group is board certified sports medicine, primarily focus their practice on sports medicine. And we gather at least once a year for our meeting, MLK weekend. And then, you know, several other meetings throughout the year. We have little, you know, lunches or
It's
breakfasts
awesome.
or whatnot. But the once a year meeting is academic in nature too. It's not just for us to
Mhm.
reconnect. We have presentations over the course of 2 days. And as a member, you have to contribute by presenting some, you know, some passion of yours, research of yours, or whatever it is. So this year I was up to present, and I decided to make it a little bit more rehab specific and not as much like surgical technique. And there's a great variety of presentations at this meeting. It's a really good meeting. And so I presented on the importance of sport specific activity before return to play. And I
Yes.
just went through and, explained why it's important, why we need to focus on this, why we have to get away from these timeline based return to play protocols.
Yes, please.
Because not everyone's not like the, cookie cutter kind of this is what happened and this is what's going to happen and whatnot. So I got really incredible feedback from some pretty big names in the sports medicine community too, which I was really flattered by. And basically people are like, wow, it sounds like you have a really good program where you are, we need to kind of replicate it. Can we have more feedback about it and maybe even, present this in another forum or another, meeting or whatnot.
Yeah.
So I was really happy that something that I'm passionate about was able to be, something that other people took a little piece from and maybe inspire them to kind of do better for their patients too, which is really,
I mean,
really important for
you
me.
have you have the platform, and without going down the rabbit hole of why healthcare is broken or our opinion on the different pieces of why healthcare is
That's a
perceived to
whole
be
nother
broken.
episode.
Yeah, right, exactly. But the specificity for me, it was actually shocking as I went through my career that I guess because I played sports and I coached sports, like there's just this natural transition into analyzing movement specific to the activity when you're trying to figure out what's wrong with somebody or how you can help them. But that's not really right. That hasn't been your experience as well, right? On the rehab side, it's always been mine. So I thought, if I'm doing it, then I'm not that bright. That someone else could be doing it and probably is doing it better. But what I just kept finding was like nobody ever told me that, and I'm like, what? So just started owning that. Like, has that been your journey
Yeah.
also?
Yeah, well, things like that kind of seem common sense to me. And I think some of it does come from the background of how I got to where I am.
Sure.
But like some of it's, I'm like, wait, how could the therapist not think that you needed to do that portion of it or whatnot? Like to me,
Those are
it
my
just makes
favorite calls,
like,
by the way. When you're like,
yeah, like what?
"Hey, I'm just wondering, is this normal?" And I'm like, "Oh my god, no, I hope not."
Yeah, I know it happens. But yeah, so I think, finding those, the reasons why we do things and making more people aware of why they should do it also is a good place to start because it's
Yes,
kind of one of the things like you don't know what you don't know, right? Like you don't even know
absolutely.
you're missing on it until someone points it out to you and you're like, oh, okay. But if they can then improve their care and then
Mhm.
someone either they get a student in their clinic or a new hire or whatever, and they can then help them along. And before you know it, we're all doing what we need to be doing instead of just doing kind of the basics. Like one of the first slides in my presentation was basic rehab is range of motion, strength and balance
My
essentially
girl.
for lower extremity, right? Like, but
Yeah.
athletes need more than that, right? Athletes need more than just your basic movement patterns. They need functional movement patterns. They need endurance in addition to that strength, right? They fatigue after a couple reps. Like that's not good enough. They need their cardiovascular fitness challenged. And so some of these things, I think, kind of to your point earlier about healthcare is, well, you only have so many sessions to get things done, right?
There it is. Yeah.
Okay.
Uh-huh.
Or your copay or your whatever. And we're not going to go into that, but
Sure,
we
sure.
have to do really good sometimes in a small amount of time or figure
Yes.
out a way to extend it beyond their, there are plenty of insurance companies around here that get 20 per year, not even mine.
It's
So
brutal.
you cannot expect to rehab an ACL in 20 sessions post-op. Absolutely no way. There's
It-
like, no matter how you spread them out, like even if that athlete works really hard, the days they're not going to PT, like the progression of activities in those 20 sessions is just not realistic.
So, I mean, quick sidebar comment on that because I agree, I agree with you wholeheartedly. And it's one of the things that like led me to go into private practice is that just the pure frustration of, hey, insurance only approves 3 to 4 months, maybe in some plans. However, what do we know about the research? Research 12 to 18 months of rehab for full boat all the way through. So how do we
Yep.
close that gap as clinicians? And I mean, my take on it is education, like you're saying, bringing up the next generation or opening people's eyes to things that I thought were common sense, and then you get enough feedback, and you're like, "You're doing what?" I'm like, "Yeah, why? Are you not?" And for me, we've been in business now, private practice, 9 years, and everybody that we onboard, I get the same feedback, no matter what their background. 30 years in healthcare, 4 years in healthcare. Like, oh my God, I've never seen this type of thought put into it. And I think that's one of the reasons you and I kind of stay hooked up, is because that fire. I mean, I'm 25 years in practice and I'm
Yeah.
still fired up about these things. So
Yeah.
with ACL specifically, can we talk a little bit just about the timeline, the expectation timeline? Because in our world, in my world, you write the protocol, you make the decisions on the protocol, which is greatly appreciated. But my level of experience at this gauge, I consider myself a specialist in ACL and return to play activities, is those are the guidelines. And then I dive into the specifics, knowing the anatomy, the biology, the physiological timeline in which there's expectations attached. And that is regularly challenged by the general public and or people that think they know, as opposed to what we know to be true. So can you speak a little bit around the ACL progressions and what you see a protocol
Yeah.
serving? Thank you.
Yeah, so I think
Yeah.
the basics behind the protocol is that there is basic science and biology that is going to guide what the ACL graft is doing and what you can do to challenge it and or protect it at certain phases. And then it's the job of the clinicians treating that patient to understand whether they may have kind of reached a certain timeline and say, okay, your graft's ready for this, but that doesn't mean their knee, their whole, their core, everything else is ready for that, because they haven't met other milestones. So the one thing I continually emphasize is these are the goals to get to, and you want to get there safely. So don't rush it if you're not able to. Sometimes people move a little bit slower, and to be honest, we usually can catch up later because it is such a long
Yes.
recovery
Yes.
that if there is a little, like, people have some setbacks with their motion, which is always one of the things that, drives me crazy. But if they do in the beginning, they have to get through that to be able to get to the next phase, and they can eventually catch up, right? Like, it's not often that, someone is so far behind that I don't clear them when I typically would clear my other athletes.
Mm-hmm.
So I think it's not going with that strict timeline because that's the timeline, even if you haven't met. So it's like two things, like, don't slow down so much, but don't speed up, because we have to handle the tissues appropriately. But at the same time, the surrounding environment has to be ready as well to advance.
I mean, so with that, I agree with you. Obviously, agree with you that it's building blocks, really. So protocol serves as a guideline. Every surgeon has a different set of protocol, but they usually generally run the same gamut of time, the first 4 weeks and then 6 to 8 weeks, 12 weeks, 16 weeks.
Yeah.
But the progressions, I'm going to voice one of my frustrations. I'll say irritation, because I am a little bit of a PT snob, but one of my frustrations really is continuously around, well, the protocol says they should be jumping. And have we done any lower impact? Have we done, okay, you want to do single leg jumping? Have you done single leg squats? Our practice serves as a second opinion a lot of times. And we go into these situations where it's like, okay, tell me where you are, tell me what you've done. And then let me see if where you're supposed to be, like, where do you fall in that gamut, right? Based on where we are supposed to be more physiologically first, like, where are you actually presenting, like, with your body compared to somebody else? And then where does that fall on the rehab protocol? Do you see that sometimes in, in your history of your practice? You don't have to speak like right now where you're practicing, but in the history. Um,
Yeah,
like,
definitely. I think there are definitely people that to come in and was like, oh, I'm doing this, this, and this already, and I've just done their physical exam. In my physical exam, I don't just, like, obviously I do a Lockman's test or an anterior drawer and, like,
sure.
test the stability of their knee, but there's more to it, right? Like, I'm looking at their how much quad atrophy do they have. I'm also looking at I have them do a bilateral double leg squat and a single leg squat, right? And if they have like absolutely no control with their single leg squat, then there's something wrong, and it's their strength issue that they have to fix first before they can be doing explosive movements. Now, can they in that time frame do some force absorption, low amplitude stuff? Of course they can, but at this, you just have to balance it out. So just because someone gets to the timeline, in fact, my protocol has changed over the years, because it used to just be like, okay, weeks through this is this phase of the protocol, and this is what you're supposed to be doing, and some examples of stuff, to the point where I actually, specifically for my ACL protocol, there are bullet points like can progress to the next phase if they have met this. And then at the beginning of the next phase, it says these are the goals, right? So you have to constantly reference what the goal is and have they met that before you get to the next thing. Like I don't care if it's 12 weeks later, if you cannot do a single leg squat, you're not going to get to do some of the things that you want to do. And I know you get bored with it, right? But that's also
Yes.
physical therapists, in my opinion, like you also have to play sports psychologists, right?
Of
Like
course.
you see them way more than I do. And the times that I spend with them, at their follow-up visits, like I have to kind of go through some of this, and they're like, okay, now I get it or whatever. But you guys unfortunately have to reinforce it over and over again, and can be a huge part of whether this athlete thinks they're behind, whether they're ahead, whether, and like even just like easing their like discomfort with like, no, I know it's a long road, and I know you're frustrated that we're not doing things that you want to be doing yet, but these are the reasons why. And so, you guys have a hard job. I'm not trying to say like you
Oh,
have the easy job by any means, but
no, that's not,
it's
that
a
wasn't my
lot of
takeaway,
stuff to take into
actually. The fact
consideration.
that yeah, but the fact that you recognize the psychological damage that's done when dealing with an athlete with ACL, you take a very competitive person, typically if they're in sports and they experience this injury, they're super competitive. There's a personality type that goes with that. And when you take them away from what they've known as most of the young people as their identity, there's a hard realization like, who am I outside of my sport? And that's usually something that I don't see. I mean, I see it all the time now, but in, maybe 15 years ago, you would see that more in the collegiate athletes or the professional athletes stepping down and retiring. But now you're seeing it in 12-year-old kids, 13-year-old kids. And one of those, I mean, it's a huge pain point that you and I have discussed over the years. And I'm wondering if this is like a really good segue into, can we use data points, specific data points, to help bridge that and help ease some of that frustration based on, I feel good, why won't you let me run, to some other marking points, because I know you use it in your practice and you have in the past. And do you see that as
Yeah.
like a more developing trend or something that we could be doing better with?
I think so. I think anytime you have concrete data for people to explain why versus just like, no, really, just trust me, like this is what needs to happen, it's going to be better, right? So if they can have this, technology give them immediate feedback of what their knee is doing in space, and they can see a difference. I mean, the good thing is also we have something to compare it to, like their other normal side, how that functions and how that is, like in general, you can see that there's a different side to side. But also it gives them goals to improve on. All these athletes, for the most part, are going to be goal oriented, right? So you give
Yep.
them not only feedback of where they are, but a goal to work towards. And I think that kind of can help engage them a little bit more. And that psychological part is, the importance of the sports specific activities. Like that's like one of the domains I talked about, like the psychological part, because if we can get them to do sports specific activities, they're psychologically ready and are more confident in their knee. So, it's not just, our, you know, biologic side of things or healing side of things or functioning side of things. So it's physical, it's psychological, and there's also like a social aspect of this too as well, if they can get back to their team quicker.
Yeah, I mean, just hitting those markers, knowing what you have to do. There's something to be said with taking a goal-oriented person and then giving them targets. So, back in the day, it used to be, listen, I want you to run up and down that 6-inch step. I want you to hit 50 toe touches in 30 seconds. So it's definitely, data points are not new to our industry because we're always looking at, as are you, but specifically always looking for baseline. And then where are we compared to the baseline? And then where are we in the timeline compared to the baseline, really, of expectations?
Yeah.
So, for us, like doing, data management or athlete management is, taking it a step further where you're engaging the patient as well, athlete as well. You're engaging the therapist, and then you're able to provide a report to you that hopefully has relevance when you're decision making, especially towards the end when they start pushing at that 9-10 month mark, like, hey, am I ready? Can I be discharged? I feel good. And you're like, your numbers don't look so hot. So let's maybe
Yeah.
stay in it a little longer. Is that
Yeah.
fairly accurate for
No,
you?
definitely. Yeah,
Yeah.
definitely. And also like, our return to play testing has been around for a while, right? Like how we
Yes.
decide if someone's ready to return to play.
Yeah.
But sometimes some of those advanced movement patterns, they may not be ready for earlier on. So this allows you to give them feedback sooner than they're ready for the return to play testing, if that makes sense. Like,
It does.
their form
Absolutely.
their form in
Yeah.
squats and their jumping and things like that is something that you can measure a lot quicker than a t-test or a triple jump and things like that.
Efficiency. And when you're talking about healthcare in general, you want what you want in a short amount of time so you can make good decisions in an efficient manner and that, is representative in the research space. And for us, like you said, alluded to earlier, straight up, if we only have 20 visits with somebody, how are we managing that? Like, when do we need to
Yeah.
see them for hands-on? When, and how are we actually doing if they're not in the office? So creating efficiencies in healthcare, or it's all the buzz, but doing it in a thoughtful, easily reproducible, and applicable way is the key, I think, to a
Yeah,
safe return.
absolutely. Yeah,
And then
absolutely.
and then the specificity of the activities, like, I think, like you said, treating a pitcher with an ACL whose landing leg is the surgical leg, as opposed to treating a soccer player. The basics are the same, but the challenges are very, very different as far as the
Yeah.
load goes. So,
Yeah.
I don't know if do you see a difference in that, like from your perspective? Probably
Oh yeah.
surgically not, but
No, definitely. Like that's a perfect example because if depends which, leg they're landing on, they're leading off of, there's a lot of things that go into it. And it's part of the reason I asked them what, position they play. So, you can also, their rehab can focus on, more force absorption versus pushing off
right.
versus, and the more they do those movements, not only is it better, like, from a physiological response. We have like Wolff's law and Davis's law, like that are bone and soft tissue related, and your tissues respond to the forces that are put across them, right? So if you're
Mhm.
putting that tissue in that particular movement pattern or whatever, you're going to build strength in that area. So it's important to do those movement patterns and not just kind of these linear um, kind of very simple, straightforward movement
Straight
patterns.
leg raises. Yeah. Straight
Yes.
leg raises with a slight little lag in that straight leg raise, which
Yeah.
drives me bananas. Right.
Yes. Yes. That's definitely one of my pet peeves.
So, oh, good. So, give me top three pet peeves when you're trying to determine if an athlete is ready to return to sport. What do you
Oh,
think?
so return to sport. So along the way, some of my pet peeves early on, honestly, I have
Okay.
probably more early on,
Perfect.
than kind of at the end.
Because I don't want to
Early
do
in the
any of your
rehab.
pet peeves. So, yes, lay it out there.
Yeah. No, like early on, if therapists are not focusing on extension from time zero and they come to me
Yes.
delayed without full extension, that really drives me crazy because I
Mhm.
know we left the OR with full extension, and I know that a lot of this has to do with what they're doing when they're not in physical therapy. But like I said earlier, you have a lot more check-ins and time points that you're
Yeah.
face to face with that athlete. So you need to emphasize, like, there should be nothing underneath your knee when you're, just resting. I make them lock their brace and extension until they have full extension. And obviously that's not foolproof, because you can have a little bit of flexion in your knee when
Yes.
it's even a knee brace
Totally.
locked. So, lack of extension that isn't emphasized, and they like act like they didn't really know that. And they're okay with just doing straight leg raises with a lag. And a lot of time it's because they don't get their full extension because they're not firing their quad appropriately, right?
Yep.
So those go hand in hand. Like, it's a quad and extension thing that has to be your first and foremost goal in physical therapy after an ACL reconstruction. I mean, get the swelling down, obviously,
Amen.
but that's what has to happen. I can get flexion usually, unless they're like really stuck and have some arthrofibrosis. But in general, extension's got to be your primary
Extension,
goal.
baby. I know we're not missing that one. Extension's the
Yeah.
queen. That's
Yes,
awesome.
exactly. Yeah. And just stiffness in general, because
Okay.
there's no way that, unless it's a multi-lig knee, like a straightforward
Sure.
ACL, even if it has meniscus work, I was struggling for a little bit. One of the therapy locations that some of my patients were going to, they were just having a lot of stiffness. And I went to one of my lead therapists and I was like, are you seeing this problem too? Like, are you really having to push them? He's like, no, that your patients get their motion back. Like, I'm not sure why that, and I was like, I don't know if it's what they're not telling them, telling the patients. I'm like, they're just like having them just sit. And I tell my patients, hey, if you're not weight bearing, like, so I mean, it depends on if you're having
Yeah,
meniscus work
sure.
done or whatnot. But in general, in the beginning, I have my ACLs weight bear and locked in extension until they have good quad control, and then they can unlock their brace. If they have meniscal work, I keep them locked in extension for a little bit longer for ambulation. But I
Sure.
tell them, even if they're locked for that, I say unlock the brace when you're sitting, right? Like, you're sitting in class, you're in a
Yes.
car, and I emphasize that. And so sometimes gets missed too. And they come to their first post-op appointment, which is usually about 10 days, 7 to 10 days after. And I've told them that, right? Like,
Yeah.
the,
Oh,
the
yeah,
key,
yeah.
the key to
Well,
adult education is repetition, right? So
well,
I've told them that already. And then they come in and they're like, oh no, my therapist didn't tell me that. And I was just like, why?
Well, because plus, I mean, listen, you're a conscientious surgeon for sure, right? So you're fact finding, not to criticize PT per se, but you want to know if there's a consistent issue that keeps popping up. Is it
Yeah.
something in the surgical technique that needs to be adjusted for a certain population, and or are we just consistently not doing the things we need to be doing? And then how do we speak to that? Because ultimately, you're on the hook for the surgery, and we're on the hook for the rehabilitation part of it. And we take that very seriously to make sure that, range of motion, I agree with you 150,000%. It's quad
Mm-hmm.
function, get the swelling down so you can fire the quad so you can maintain your extension. And until you can fire the quad, you have to keep pushing extension. And if you skip
Yeah.
that, you lose it, and then you start the cycle all over. So,
Yeah.
totally agree with you. I get fired up just thinking about it.
Yeah.
So
Yeah.
no, it's really great stuff. I'm so excited that you were talking to us about all this stuff, and I hope that you will come back and talk. We'll make some other episodes that you'll come back and talk to us
Oh,
about. Like, I want to get
absolutely.
into like rotator cuff repair and specific for overhead athletes. I want to get into instability for the
Yeah.
shoulder for sure, because I have found even after all these years, it's one of the more challenging things to rehabilitate and determine
Yeah.
if you're progressing or not progressing. So
Yeah.
if you would have us again as opposed to me having you,
Absolutely. Yeah,
that's awesome.
absolutely. I would love to do it. It's always good to just chat and talk things out.
Oh my God. It makes it, even though we're so far away, it's like the kinship and what we're trying to
Yeah.
accomplish is very, very strong. So I appreciate it.
Yeah,
Any last
absolutely.
like takeaway points, especially around that? If we're talking about general population, what you should expect to experience in PT, or what we would hope to set the bar at experiencing in PT prior to going back to sport, anything around that
Yeah.
topic? Yeah. So if you
Yeah,
have
I would
any good
say the
takeaways
biggest
for
thing
that, Chris,
is
yeah.
Okay, so I would say in general, if you're just going to a physical therapy clinic and they're just kind of getting you through the basics and at 3 months they're ready to discharge you, you got to find a different place to get you through to your clearance, because what is really dangerous is for you to think that you're ready and you just have to sit around and wait for the calendar to fly by, and then at 9 months you're just going to go back. Like, if you've deconditioned, first of all, you've not enhanced any of your functional movement patterns, and there's no way you're ready, and you're not going to protect your new ACL, and you're going to be one of those really unfortunate people that has a re-tear. So in my opinion, you have to continue to work, even if you've been discharged from physical therapy, right up until the day that you're back with your teammates. You have to be able to participate in some kind of physical therapy or kind of program to bridge the gap between when you finish therapy to clearance, return to play. And then return to play can't be, okay, I go from 0 to 60 immediately. I say, in general, you can start with skill work, depending on what sport you have, whether it's foot skills, racket, stick skills, whatever it is. Then you can increase your conditioning during that time frame. You can go back to lifting with your team, and doing basic conditioning stuff, and that gives you your team mentality. And then you just can't do contact maybe right away. So then you're going to be practicing with them doing 1v1, then 3v3, and then eventually you're going to get back in their full scrimmage but non-contact, and then eventually contact. So there's a whole continuum of return to play, and you cannot stop your physical therapy early in that recovery and think that you're just going to go right back onto the field for a full contact play. Competition is even practicing for a while before you even get onto the competitive field is something to consider too. So you be smart about it, and hopefully we can keep you healthy that way.
Oh my God. Can you please come back down here? Please come play. I know your current situation will burn me at the stake for even making that suggestion.
Yeah,
But
we're doing good right now, but I
I
appreciate you wanting me
know.
back there.
No, my God, are you kidding? I'm just going to keep dragging you on this, and so we can talk shop all
Yeah.
day. So,
All right. Sounds good.
everyone, Dr. Kristen Herbst, an orthopedic surgeon with a specialty in return to play and progressions. So grateful. Thank you so much. And we'll check you guys later. See ya.
Thanks for inviting me, Andrea. Take care.
Yes.
That's a wrap on this episode of Expect More with Dr. Andrea. I hope you're walking away with something real, something that challenges how you think about your health, your care, and what you deserve. If today's episode hit home, share it, leave a review, and make sure you're subscribed so you never miss the real talk. Because in a world that keeps shifting, one thing is constant. You should always expect more from your providers, your movement, and yourself. Until next time, keep showing up, keep asking questions, and never settle.